It's all good. It's all good. Well, my name is Daniel Need. I'm a clinical psychologist and the director of integrated health at Malami Keola Health Center over on Maui. We're an FQHC that serves pretty much the entire island aside from Hana, who has their own. And we've been working for probably the past 5 or 6 years on increasing integration here in our clinic and sort of the different iterations of how that's happened. I've been the director for the past 2 years, so I can kind of talk some from my experience as both as a clinician and then also kind of in the role that I'm in now as a administrator, as a manager, and how this is rolled out. But I will say I've been working in this field for probably 10 years, and I still don't pretend to know everything. So I'm certainly not going to give every answer in the next 60 minutes. But I do want to kind of talk about some of the kind of basic ideas, things that you all would want to think about if you're thinking about integrating, and even kind of what integration would look like in your setting. So again, this is me. Just so you know, I'm a real person who actually knows what I'm talking about. If you didn't see my previous presentation, this is not shameless self-promotion. I did talk a lot back in April about the different integrated care models, the theories behind integrated care, why integrating behavioral health and looking at things from like a population health standpoint is really important as our health system changes. And I think if any of you saw John Oliver's recent talk or his recent episode on the American mental health system, he talks kind of a lot about that too. So I'm not going to get too much into depth about that stuff because I covered that already, and I certainly wouldn't have enough time. But please do, either get a copy from here, or we can make sure this gets sent out so that you guys have that for reference too, because I'm just not going to get too much back into that. But here is what I want to talk about today, which is kind of just the basic steps of assessing your needs, your resources, kind of what your abilities are and what you're looking for as far as possibly integrating behavioral health into your practice, choosing the right model and the right way to do that based on kind of what you're able to do, willing to do, what goals you have for integrating care, what it looks like to hire new staff and or train existing staff to kind of shift models and shift the ideas of what healthcare and what primary care as a whole looks like. And then some basic kind of ideas about how to implement that. Once you've done all the planning and have everything in place, how do we actually make that happen and make sure that all the work we've put in is actually going to turn out to get us what we want or get close to what we want. First step, as we would imagine with any kind of project, is kind of figuring out where are we starting, right? What are the tools that we have? What are the resources that we have? And what are we going to use to build the place that we're going? Just a quick review of kind of what integrated health or integrated behavioral health is as a concept. It's this idea of merging what were traditionally two very separate and very siloed forms of care, which was medicine and mental health, and putting them at least in the same place, if not within the same service, to provide more kind of holistic patient-centered care. As we all know, recognizing the mind and body are very much connected, and if we're not treating one, we're going to have a hard time treating the other. Integrated health can also address everything from mental, kind of your traditional mental health, mood disorders, substance use, health behaviors like diet, exercise, sleep, as well as sort of the daily life stuff that happens, like global pandemics and starting school, or parents getting divorced and changes in families. All of these things would be aspects of patients' health that can be addressed through integrated behavioral health. I used this book a lot, and I do really recommend this book for anyone who's looking to integrate behavioral health into their practice. This is a great tool that really kind of outlines steps that you would need to take. Again, going from kind of all the way from your initial assessment of where are we starting to looking at kind of the business case and your ROI and upfront costs, all the way back to how do we evaluate this program for effectiveness. once it's been up and running for a while. So I would say this is a must purchase for anyone. And I will have a resource list of everything at the end that will include this. So when we're talking about identifying your initial needs, this is going to be really important to determine the next step, which is figuring out what model is going to be best for you. But we also want to look at, what are our reasons here for wanting to integrate behavioral health into a pediatric service. The first question is going to be is who within my practice is going to use this? Are we looking at like a population? We're going to kind of focus it on patients with maybe from a certain areas, certain groups. It might be patterns of healthcare use, like kind of our high utilizers. Are we going to look at diagnosis? Are we going to say everyone that has a diagnosis of depressive disorder, or dysthymia, or anxiety, or school separation, or attachment stuff? Are we going to look at a percentage of population? If we use more of a kind of traditional primary care behavioral health model, where we're going to have someone sort of as almost like a co-provider, and I want 20% of my patients to be seen and screened, or have some sort of intervention for their behavioral health. Who are we targeting with this service? We also want to look at, and these two things are related, what are our clinical needs, right? What are our patients coming in asking for things that we're not able to provide them on a behavioral health level? That could be education, that could be clinical services, that could be intervention. We also want to say, what are the needs of your staff? Do you hear either other providers within your practice or other staff? Boy, I really wish we had more, whatever. Man, I see so many people that need help with this, and I just don't even know what to do. You can kind of listen to where the need is just within your clinic and say, is there a way that we can add behavioral health in here to support the services that our staff are already giving, so they're feeling like they're providing better care, and also not straining to provide care that they're not necessarily trained to provide, which we know can lead to burnout and poorer levels of care in general. And also, again, what are the goals of this service? That can be split between, I want to look at patient outcomes, I want to look at staff outcomes, staff satisfaction, happiness with their job. Are we looking at HEDIS measures and our annual UDS goals? How are we going to know this program is working once we do have it up and running? Again, this is going to help us know kind of what direction are we going for, and if this is where we're trying to get, or this is the group of patients we're trying to reach. That helps us figure out how to get there most effectively. We also want to ask, how integrated are we already, right? If we're starting from a place of no integration, where maybe we're not even screening for, behavioral health concerns, then we're not going to pick a model that's super complicated, because, if you're learning to drive, driving a semi-truck is not probably the easiest way to learn to drive, right? You have a two-door Honda Civic, automatic transmission, we start small. If you are a practice that has good working relationships with behavioral health providers or schools, and you're used to sort of having these conversations and incorporating behavioral health is part of the care that you're giving, and you want to bring some of that kind of on site and integrate more, then a model that kind of does that might be an easier change for you and your clinic. So we want to just figure out kind of what skill set and if integration are we starting with just from the get-go. Related to that, what resources do we have available? Do we have office space that we could give someone if they were here every day seeing patients one-on-one or not? Do we have an EMR that can support behavioral health? And do we have people that can do billing and know what to do with billing rejections and how that coding needs to go? Or is that something we could outsource and contract? All of these things are just questions we're going to have to ask. Do we have the bandwidth? Integrating a program, any kind of program, over the past 2 years has been really difficult because people are tired, and their bandwidth for change is just not really big. So kind of looking at that. Where is your staff readiness? Where is your clinic readiness to implement any kind of change in your clinic right now? And then also looking at how do you want to structure staffing? If you bring someone in to do some of this work, is this a contracted worker that you're paying by the day or by the hour? Is this someone that's going to come in and do their own billing and they're kind of just getting referrals from you and using your office space, but you're going to keep, two separate sets of books and they're going to kind of do their own thing? And you're really looking at like a BAA. Do you have the funding resources, right? If you bring someone on to take time to get that practice built, where even if you're billing for them, there might not be a lot of income at the beginning until they kind of get things going, and can you make that buffer? So even looking at how do you want to bring people on and how is that integration going to happen kind of at an administrative level is going to be important. Looking at your timeline. Is this something that you want to happen fast, or is this something you can take time to do? Again, that's going to determine how complex of a model that maybe you're going to start with. You also want to look at how will this service sustain itself, right? That again kind of goes back to billing, but it also is going to look at your patient population, right? What's your payer pool? If you're working with 50% of a population that is 50% uninsured, what is their access to a behavioral health clinician if they're paying cash out of pocket? I don't think in pediatrics you have a huge amount of Medicare patients, but like for us in adult, Medicare still has a copay for behavioral health appointments. So if someone's having to pay $15 to $20 per visit, that might be a barrier for some people. We also want to look at, again, the outcomes of how do we know it's working? How do we know our patients are getting better? Part of sustaining a service is kind of the emotional part of knowing the work and the effort that we're putting into it, and the work that we've done to set it up once we get it going is actually doing something positive for us. So we can again look at the clinical outcomes. Are we seeing changes in PHQ-A scores? Are we seeing fewer prescriptions for SSRIs or ADHD medications? Again, staff outcomes. Is our staff happier? Do they feel more satisfied? Do they feel less stressed trying to fill in care gaps that they don't know how to fill in? And then looking at staff and patient feedback. Sometimes your clinical outcomes aren't anything amazing, but people are really happy they're getting the care here, and it keeps them engaged with their healthcare, and it keeps them thinking about their health. And there's a lot of power to that as well. So just figuring out how are we gonna measure these things. And again, things like clinical outcomes, maybe we can pull those reports from the EMR. If our EMR tracks the things that we want to be tracking in the way we think that it's tracking it. If it's staff outcomes, is that part of like, an annual survey or performance reviews, or are we going to kind of look at this formally or informally? So again, just things to think about as we're thinking about any kind of change management. I think all of these things are probably relevant, but especially with kind of integrating behavioral health, we want to really think of everything from staffing to office space to billing to who exactly do I think is going to use this service. That helps us choose the model, right? If we know what we're doing, if we know where we're trying to go, then we can figure out what's the best tool for getting there. And so choosing your model is going to be literally the most important thing that you do in this whole process. Because if you're trying to build a house and you buy a bunch of paintbrushes, you're not going to get very far. So you really want to know where you're trying to get, and you really want to know what tools you already have, what tools you might need to get, and you're going to use that to decide, okay, if I have that and my model is my blueprint, I've got all the things I need to build the thing that I want to get to. Also remembering there is a huge range of integrated behavioral health models and ways that you can do this. Again, I talked more in depth about this in my previous presentation, so I'm not going to get too deep into this now. But again, going from really minimal collaboration, which is sort of the setup that we have with a lot of our medical specialists, where we sort of refer the patient there, they see that provider, the provider sends us a note, and kind of that's the long and short of it. all the way up to kind of full collaboration, where you might have a behavioral health provider who is on your primary care team seeing the same patients that you're seeing, using the same schedule, and just you guys are kind of working on a co-treatment plan. It's just making sure you're including all aspects of the patient's health, and that both providers are able to address all the parts of that plan. So it really can run kind of everything, but you are going to kind of want to look at using a model, if nothing else, is really as guidance, right? No model is going to fit everywhere perfectly. And so, saying that I can just wholesale take this and drop it in and it's going to work is probably not totally realistic. But that being said, models are really important to provide a lot of structure and predictability. You are going to be taking, again, two healthcare cultures that have traditionally been very separate, and on some amount merging them together. And models of how to do that, and models of what we would want it to look like, and how these things can run, can be really helpful in making sure we're doing what we think we're doing, and hopefully getting to where we want to get to. Models are also important because we are really doing a fundamentally different approach to healthcare. And that's going to come from both the clinical side of things, what kind of care we're providing, how we're providing that care, how we're documenting and communicating that care, even just how we conceptualize, behavioral health and physical health, and how these two things interact, can be really very different for people. So models can also help kind of guide our thinking and guide our learning as we're making some of those sort of cognitive and systemic changes to how we're providing care. Models are also super helpful on that practical admin billing side. How do we set up schedules? What codes are we going to use? What documentation needs to be in the note for behavioral health visit, so that it passes muster with insurance companies? Are there any billing restrictions? How do we do confidentiality when we have two different providers? All of those things can help be kind of guided through by using a model. And so kind of, again, picking the model that you need becomes very important. You also want to, as you're picking a model, make sure you're matching your model to your clinic. Going back, where is your staff with the idea of integrating care? Are they into this? Are they open to this? How are we going to kind of make this change internally in just the way we're approaching things? Again, if we go from zero integration to like a full-on, fully integrated behavioral health team, right, that has another licensed provider kind of co-providing with the pediatrician, that's a really big shift for the whole system. So, again, match the model to what you think is doable for where you are right now. We also want to look at things like how open is your staff to, mental health patients, and how is, are those terms really even used? Some, stigma exists within patients and within the healthcare system. So, again, kind of, if you are going for a model that's going to treat, patients with psychotic features or psychotic symptoms, that might be a much harder sell to your patients than saying, what if we did patients who were having some anxiety about going back to school? That might be a much easier sell. So, again, what kind of change are you asking of your system, including the people within it? You also want to look at hiring and staffing. If your model requires you, for instance, to have a psychiatric provider and there's no psychiatrist for you to hire, you're missing an integral tool to that model. Again, looking at, is this going to be a provider that we're going to have contracted or on staff? Are they full-time? Are they part-time? All of these things are going to determine the level of service, the kind of service that you can provide. And so sometimes your model choices are going to be limited on your available resources of the other professionals in your community. Again, looking at workflows and care management, what's the existing structures that you have? Can I build off of that? Can I build into that? Do I need to overhaul all of it potentially? These are all things we're going to kind of want to look at when we're talking about the degree of change that we're hoping for or expecting. And then again, looking at availability of resources. Something like a co-located model where you have, a behavioral health provider who's sort of doing their own thing might be much easier because all they need is a room, versus someone who, like in the collaborative care model, who might be doing care management, it's going to have to run a registry, have EMR access, have much kind of more common communication with the team. Is there space for that? Is there time for that? Is there willingness for that? So again, looking at kind of your soft resources like people, time, and energy, as well as your hard resources like office space availability, technology, and the ability to hire the person you want to hire. We also want to look at matching our model to our goals, right? So figuring out why am I doing this? Where do I want to go? What do I want to see happen from this? And then picking the model that's going to help you to get there. If this is an identified population that you want to look at, if you're seeing there's a certain population that seems to be falling through the cracks a lot, something like a care management model that has more frequent contact might be, a better choice. If it's a population that is reluctant to engage in mental health at all, then a co-located model where you're putting the therapist in, right there, may or may not be useful if the issue is the therapy and not getting to the therapy. So figuring out, how is your population going to engage or willing to engage with the service? Also, again, any identified care gaps, right? Are there things that it's just hard as a PD in your current setup to meet the needs of the patients that are coming in? Those might be, again, patient identified things where people are coming in asking for help on things that you don't have the background or the resources to help them with. And it can also be kind of the other side of, I wish I could do more. I wish I could treat this myself. I wish I didn't have to refer these patients out. And then also looking again at quality of life and burnout prevention. We know that that's a huge problem in healthcare. And so to be able to kind of use a model that's not going to put a lot of added stress on, might be something we want to factor in. If in the long term that short-term added stress is going to make things a whole lot better down the road, great. Then we factor that into how we talk to people and how we explain this and kind of what our timeline and our rollout for this is. But we do want to remember, we've had a lot of change these past 2 years, and adding more big change may or may not go over well with people, just depending on kind of their feelings about the need for this, and kind of just where they are with life in general. CPT codes are also going to kind of run the gamut a little bit. You're going to go from your more traditional on the kind of the co-located end of things, where we're talking about kind of just taking two services and putting them in the same place. You're still going to have E&M codes for your medical providers and the CPT codes for your behavioral health providers. As you get more into a collaborative care, where you talk about like maybe the collaborative care model, or even some of the primary care behavioral health things, you start to see then where some of these CPT codes actually can be used by multiple members of the team. So whether that's the care manager, whether that's the medical provider, whether that's the behavioral health provider, things like screening codes and preventative medicine codes, some of those can be used by both. And so again, depending on what model you're using might kind of open up your billing possibilities as well. So really quickly, I'm going to run through the three main models that I talked about last time and kind of what that would look like from an implementation standpoint. So I'm going to start with co-located mental health. So this is really kind of taking kind of the existing system of mental health is over here and medicine is over here, and we have two different treatment plans treating two different sets of diagnoses with two different providers and just putting them in the same place. Really what is this model from a behavioral health standpoint really looks at just providing your traditional mental health service in a primary care clinic. It's not really much more complicated than that. So your treatment focus is going to be all of your traditional mental health kind of things when we think about mental health, right? Mood and behavior issues, general life changes, family dynamics, parenting skills, developmental issues, and being able to sort of assess and address those things. Your staffing requirement there, because you're providing a clinical service, would require some kind of licensed independent provider. Again, for a pediatric population, you probably don't have a lot of Medicare patients. Like for us in adult, we get limited, for instance, to psychologists and LCSWs because of Medicare. For instance, in Hawaii, licensed marriage and family therapists and licensed professional counselors can bill Medicaid, but they cannot bill Medicare. So like for us, when we hire, if we hired someone who were working just with peds, an LMFT might be fine. If we were hiring someone to work in adult, we'd have to decide, well, what's our payer mix here, and how much would we miss out on billing because of who we hired. So again, these are things we're just going to kind of want to keep in mind depending on the model, the population, and any kind of payer restrictions. This model is just going to use your traditional psychotherapy CPT codes. It's not going to change any kind of billing for any other member of the healthcare team, because you're again just co-locating two services and not really overlapping them much. So again, just a quick and dirty, the pros of this is the model that's most familiar to patients, because you're providing essentially traditional specialty mental health, therapy. You're just putting it in the primary care office and making for easy referrals. This is also usually really helpful because the patients who come are identifying that they have a need, so they're more motivated to engage in care. And this has really a minimal impact on clinic and workflows, because you're two different providers doing two different things. Possibly even, again, if you just contract someone to come in and use the space, they might even be doing all their own billing, registration, scheduling, and everything else. So it could have really minimal impact on your current workflows. The cons of this model, it is still the most kind of siloed and separate of the integrated care models. So even though it's in the same place, you're not necessarily going to have a lot of overlap unless you really make an effort to communicate about patients, especially if you're using two different EMRs. It doesn't address a lot of the non-mental health issues that can present in primary care, like adherence, chronic disease management, kind of non-traditional mental health issues like pain, or sleep, or things like that. So it's a bit more limited in kind of what it would be able to address. And it does require dedicated space and scheduling. So it is a model that requires a room where a patient would be seen by the provider, that they'd be scheduled ahead of time, and you'd have to figure out, is the provider doing the scheduling? Is your office doing the scheduling? Is the schedule full when the provider comes in? Because if they're doing their own billing and you have them come in and they only see 3 patients that day, that's income they're losing. So, it requires a little bit more because you're running 2 separate schedules and making sure that happens. So you got to figure out what works for you there, if they're doing their scheduling or if you are. The primary care behavioral health model is sort of the other end of the spectrum. This is where you're providing kind of the primary care version of behavioral health alongside the primary care medical care. So this is putting a behavioral health provider in the pod on the team, who's kind of working as a CNL service, essentially. So they can see the patients when they're there for anything that might come up, and they might do some short-term follow-ups when the patient comes back in, or even do a little bit of scheduled follow-ups for kind of short-term things. Hey, we talked about this last time. How's that going? Did that work? Great. If not, maybe we talk about referring you to a specialty provider in the community. The treatment focus here is going to be your traditional mental health and substance use, but also your health behaviors. So again, kind of being able to address really anything that walks into primary care. And this is also going to require a licensed provider because you're providing a direct clinical service. Your CPT codes for this are going to also, again, be a little wider. The blue are your E&M codes that your medical providers can bill for, and the pink ones are what your behavioral health provider can bill for. So you can use your traditional psychotherapy codes if what the patient's coming in for is something that's mood related, and you can use the HBAI codes for things that are medically related. So diabetes management, disease management, anything that isn't directly addressing kind of a diagnosable or a subacute mood disorder. Pros and cons of this one. The pros here is you see the largest number of patients for the widest variety of reasons. So I could see 10 patients in a day because I'm only seeing them for maybe 15 to 20 minutes each. because we're not talking about providing long, ongoing care for people with a kind of a more severe level of mental health need that kind of would reach a diagnosable level of care. You also get same-day access, so patients don't even need a referral because you're already there. Again, as a CNL, you can just walk into the room while the provider's in the room, and the three of you all can talk, or you can go in after the provider goes in. So it makes access to care for patients very simple, very easy. And it also requires no extra office space and really no additional scheduling unless there's the occasional follow-up. Again, the behavioral health provider is in the pod on the team, looking at the same huddle sheets, and kind of doing seeing the same patients that the medical providers are seeing. So it doesn't require kind of all that, the extra work of separate schedule, separate patient load, separate treatment plan, all that kind of thing. The cons of this are, this does require kind of the highest level of specialization and training. You would need to find someone like a health psychologist or someone that's been trained in the primary care behavioral health model, because most traditionally trained behavioral health providers aren't going to know what an A1C is, or the difference between A1C and blood glucose, or the different kinds of hypertension. Well, it's hypertension pediatrics, maybe not so much. But kind of the medical side of things, and kind of a lot of the psychophysiology that would be needed to look at some of the medical needs that patients might present with. This is also a model that's less familiar to kind of the existing medical system and payers and even patients. So you can sometimes run into, especially at the start, billing issues, because you're going to start using new billing codes and how those notes are documented, and if those codes are open already in whatever contract you have with your payers, you may have to check, or they just may not be familiar with them and not know what to do with them. You would also need on your side to make sure your EMR can bill those codes. And so if anything had to be activated or turned on or changed, to make sure the billing and the documentation could happen for that behavioral health provider in your EMR would also have to be done. There's a great book on setting this up. I highly recommend this. Patricia Robinson's been doing this for a very long time, and she's kind of one of the go-to people for the primary care behavioral health model. So if this is a model you're interested in or interested in starting, this is the model I've trained in and that I do a lot of my work in. I would really recommend this book to check this out. For the collaborative care model, this is sort of the middle point between the co-located and the primary care behavioral health, and sort of putting things in the middle where you're providing kind of a subspecialty amount of care within the primary care setting. So this looks at kind of tracking a specialized caseload of identified patients using a treat to target approach. So you're kind of repeatedly monitoring symptoms and adjusting care as needed, usually medical and behavioral health care, to get the patient to the goal that they're looking for. This treatment focus, again, is going to be mostly mental health. Traditionally, it's been done with anxiety and depression. Your staffing is going to require 2 people. One is going to be your behavioral health care manager. This could be a licensed provider who would then also be able to provide direct clinical services and bill for those. You could also use a non-licensed provider like a social worker or an RN who's been trained in this model specifically, and they can bill certain collaborative care codes. They're not going to reimburse at the same rate that a licensed provider would reimburse at, but it does help cover the cost, because this is a kind of a different model that is not necessarily direct care based as much. You also would need a psychiatric consultant. This is a part-time. You're really only, if you're running a full caseload, you're really only needing someone that could do 2 or 3 hours a week. So that may be very doable for someone. That may be also hard because sometimes people like having a full-time job, and so asking for evenings and weekends may be a harder sell. Your CPT codes for this, again, are going to be your E&M codes that you would use kind of in pediatric medicine anyway, as well as your psychotherapy codes. For the license, if you were to hire a licensed provider, your behavioral health integration care management and collaborative care management codes would be used by the psychiatric consultant and the care manager when they're doing either non-clinical work, or if they're not licensed, then kind of all the work that they do. as far as registry management, outreach, and case consultation. So the pros of this one really requires the least amount of training and credentialing. You don't need to hire a licensed provider and get them, in with the insurance companies and accredited and all of that sort of thing. It does a mix of traditional medicine and prescribing and follow-up, as well as kind of mental health screening and treatment and intervention. And it can be done either on-site or virtually. Because this is a lot of kind of care management, this could be, even the psychiatrist doesn't have to be on-site, as long as there's kind of full communication between people and with patients. You wouldn't necessarily need office space and something kind of right there in your clinic with you. The cons of this is that you have to find a pediatric psychiatric provider, which are few and far between on the ground. The other is that it requires more interaction between people. So there's a lot more ongoing communication between the care manager and the pediatrician, the care manager and the psychiatric provider, the care manager and the patient. So it's more work on that front, and that you do a lot more back and forth because of that level of integration. And the pediatrician and the psychiatrist, if they're the only licensed providers, then have to provide a lot more guidance and care for the care manager, who's then going to kind of enact the treatment plan.
There's actually a really quick question on that. I'm just going to interrupt you for a second, because there was actually very specifically a question on how structured or flexible is the time that the psychiatrist provides specifically within this care model.
Again, there's going to be a certain amount of flexibility for what the need is. You want the psychiatrist to be looking over. Generally, a registry is used to sort of track progress, so the psychiatrist would have access to that, as well as the care manager. So if everything's going fine, then the psychiatrist may just have to sort of do a cursory review of things. If the pediatrician has a lot of questions about medication prescribing, if there are patients who aren't improving, despite sort of shifting the care that's being provided, then that might require more of like a chart review by the psychiatrist, or even a consultation with the patient and the family. So it can vary a little bit, but kind of the general gist would be 2 to 3 hours, because most of the time you're not necessarily asking them to see patients. You're really they're meeting with the care manager to go over the existing caseload and figure out any needs that are there.
Okay, thank you. There was one follow-up question. I normally hate interrupting in the middle, but the follow-up question
I'll talk forever, and we're already
I know. I know, you're so amazing at that, thankfully. Oh my gosh. So the question was, is this more work and care intensive and less reimbursement focused, so possibly grant related as a model, or how does that part work?
I mean, it can be, depending. If you hired a licensed person and they can, in part of that care management and calling patients and checking in is also providing some sort of intervention, then that is a billable service. So you could have more income that way. However, you'd probably be paying that person more as a licensed independent provider than you would an unlicensed care manager. This is a model that a lot of people are moving towards, and a lot of the payers are moving towards, because the idea of being able to send individual patients to see psychiatrists for one-on-one appointments that system really doesn't exist anymore. So many psychiatrists have retired, and we're just not replacing them. I think in the last statistic I read from the American Psychiatric Association was that in 2015, 60% of psychiatrists were over the age of 55. And we're 8 years later. So, we're talking about a huge number of psychiatrists who are either past or at retirement age. We're going to have to start moving towards this. So it may not be the most reimbursed now, but I think as more people are doing it, and as we're all getting more used to it, I think insurance will catch up, because they'll start to see that it is necessary. And they've adjusted with some of the other, like the health and behavior codes have adjusted because of that too, as those have gotten used more. So I think it's an ongoing process, but you could also make a case for your insurance, with the insurance panels you use. If this reduces ER visits, if this reduces inpatient admissions, if this reduces, like issues at school, they, we're in FQHC, so we're a little kind of bound by certain, like federal restrictions. But when you guys negotiate with your payers, if you're able to kind of make the outcomes they want to see, that's a whole different thing. So if this was like a quality-driven project that you guys did as like a test pilot to as a kind of proof of concept, call your payers, make a deal, see what you guys can come up with. It's always cheaper than sending a kid and a family to the ER. So you can always, there's always that argument. The AIMS Center at the University of Washington has a great step-by-step guide that's free online, that has all sorts of worksheets and really walks you through even setting up a planning committee. It talks about billing, it talks about all kinds of things. If this is a model you're interested in, I highly recommend this. Even if you're interested in another model, you can use a lot of their implementation stuff to implement a different model as well. So this is a great resource kind of just in general. The American Psychiatric Association also has a great ongoing series of integrating kind of what's essentially the collaborative care model into primary care in general, mainly because the COCM, the collaborative care model, is a psychiatry-driven model. So they've got some also great resources, webinars, CEUs that you can look at and use to get more information, get more ideas, and again, just sort of start thinking about how this could play out or how you would want to implement some of these things. So once you've got a model, once you figure out what you're doing, how do you make that actually happen? The main thing you're going to want to look at in orienting your staff to your program is that you need to include everybody from the front desk to your admin people. Everyone's going to have to understand, we are making a fundamental change in the way that we're providing care and how we're conceptualizing care and how we talk about care. Patients are going to call to make appointments. They're going to have questions. Make sure you've got, everybody involved in any changes that you're making to your clinical practice. Also look at things like warm handoffs, referrals. How are you getting patients to your behavioral health provider, regardless of what model you're using? Are you doing screenings? Are you doing universal screenings? Are you doing targeted screenings? What kind of screening score, requires some sort of follow-up? Are we going to look at clinical indicators, right? Patients that have certain diagnoses, or are we going to look at patients with, certain number of visits within a certain time period? How are we identifying these patients and then getting them to the behavioral health provider? Looking at how are we introducing this program? How do we talk to about this new service that we have with our patients? How do we advertise for it? How do we incorporate it into sort of the care that we're already giving? And making sure everyone's giving, kind of similar messaging and has similar comfort talking about mental health and depression and anxiety. And doing it in a way that's non-stigmatizing so that patients want to engage in this new service we're giving. And then looking also at workflows for acute behavioral health needs. If a patient comes in and they're saying they're suicidal, what do we do about that? Is it active suicidality? Is it passive suicidality? Is this an acute issue? Is this a chronic thing that's been happening? But what do we do to make sure, now that we're asking these questions, what do we do with the answers? So, just like we would, if we take someone's blood pressure and that's, 175 over 105, we know what to do about that. We need to know what to do when we get kind of our behavioral health vital signs that are out of the norm and what constitutes an urgent versus an emergent situation. Looking at the non-behavioral health workflows, what happens if patients miss appointments? Who's rescheduling? Is that the BH provider? Is that the office? How are we documenting? Are we having a shared EMR? If it's a co-located model and you've just got someone coming in and using your office space, how are we going to communicate if you're using your EMR and I'm using mine? Are we putting everything in that documentation that we need for insurance to reimburse us, right? We all know there's sort of the minimal required things that our notes need in order to pass muster with the insurance companies. And then looking at billing and reimbursement, right? How are we coding for, doing screeners and preventive care, which for instance, in an FQHC, we can't do. But there is coding every time I give a PHQA. If you're in private practice, you can bill for that. Also looking at coding for your behavioral health services. Again, that chart with all the different types of CPT codes, that's all going to depend on what service it is you're providing and what diagnosis that service is treating. So kind of knowing what we're coding, how we're coding, what we're billing, and how to get our payers to pay for that coding and that billing. And then that gets us to kind of the implementation part, right? Which is how do we actually make this all happen once we know what we want and we think we know how we're going to do it. Again, the most important thing you can do from this whole process is implement all of your staff at all levels from the start. Nurses have a different perspective than providers who have a different perspective than the front desk people who have a different perspective than admin and billing. You're going to get all different kinds of multidisciplinary insights of how people provide care. You're also going to get a lot of good information about the cultural dynamics around mental health and behavioral health, and how do we talk about things? How do we not talk about things? How do we engage different patient populations in the care that we want to provide? It's an invaluable resource to, especially if your staff is from the communities that you're serving, to have them involved from the get-go as you're even starting to conceptualize what this looks like, so that you're really building something that your patients really want to engage in. How do we incorporate this into some of our existing clinical structures? If you're doing PCMH, this is an easy thing to integrate into PCMH, and looking at how we're providing better, more holistic, involved care. How do we make sure our referral process is solidly in place? Again, is that referring internally? Is that referring to community providers? How do we make sure that that happens so that we're making sure we're getting the patient from the medical appointment to the behavioral health provider in whichever way we want to, based on whatever model we're using? And then making sure our communication is solidly in place. Any kind of integrated care model that you're going to use is going to require you to have ongoing communication with another provider. Depending on if you're in the same EMR or if it's two different EMRs doing two different services, you're still going to want to be able to talk to that other provider about those shared patients. So if it's not an EMR thing, is there time you're setting aside to sit down and go over shared patients and any needs, acute needs that might be there, anything that the behavioral health provider is seeing? How is the rest of the team communicating about these topics, and making sure they're comfortable in talking about it and being able to talk about it in a way that is accurate and is helping to provide good care. And then looking at outcome and quality measures. Again, do your patients like the service you're giving? Do your staff like the service that they're giving? Is this model and is this program a good fit for your practice? And again, that can be looking at formal quality measures like your UDS scores, or informal quality measures like staff turnover. Also, again, looking at how do we communicate with our patients this is happening once we have it. Are we targeting our outreach? Again, looking at patients who have certain diagnoses and reaching out to them proactively. Are we putting up flyers and in the clinic and the exam rooms? Are we including it with our registration paperwork? This is something that we have, and if you're interested, call this number or tell us. And then how do we pitch it, right? How do we sell this to our patients, and have our little kind of elevator speech that can kind of quickly and easily tell the patient, hey, here's the service we have and here's what it does, and here's why I think it would be potentially important too. So the takeaways, quick things to remember. Figure out where you're starting, figure out what you want to do, what tools you have available to you, and how ready you are to be making that change. Picking your model is going to be the most critical thing you do, because you have to pick a model that matches the tools you have, that's going to build you the thing that you want in the end. Make sure you're involving everyone from the get-go, from, again, front desk and call center all the way to admin and billing and everyone in between. They're all going to have really valuable insights into how to make the different aspects of this process work. And don't be scared of iterative, like kind of doing this in small steps. You don't have to do everything at once. Maybe you start with, we're just going to get screenings and do universal screenings and talk about that and really use the information from there to understand our patient population better. And then we'll start talking about, okay, how do we connect patients to services? So integration can happen in small steps. You do what works for you and what makes sense for you and your practice. This is just a brief overview again of those three main models, looking at what kind of provider you would need, kind of the workflows you'd need, what areas of care it provides, the specific services that are provided, and then the admin side, on-site versus off-site, what CPT codes, how you document, And then just remembering the degree of change that you need is going to is the same as the degree of impact you're going to have, right? So if you're switching to a behavioral health primary care model where you're having like 2 providers on a team who are seeing all the same patients, that's a much bigger change, but also a much bigger impact, because that behavioral health provider then might see 15 patients in a day versus a traditional behavioral health provider who might see, in the co-located mental health, might see 6 patients a day, because their need is more acute and their needs are more intense. So, figuring out all of these things, there's no right, there's no wrong. It's just really figuring out what's my goal, what am I working for, and what do I want out of this.